morning. This is a presentation on consent and refusal in children. And this relates to the law of England and Scotland, and also the stance that the General Medical Council has taken. And I believe that this is also the stance of most European and United States and other countries as well. So in order to do that, I'd like to revise some aspects of adult consent and refusal, which I had discussed in an earlier presentation, and I hope that you have an opportunity to review this as well. So here goes my presentation in respect of the consent and refusal insofar as children are concerned. So talking about consent in adults, one would readily see that the aspects that we need to cover are what is consent, why is it needed, how is it different in children, and what if a child has learning disabilities. And of course, towards the end, we will consider ourselves as to what the implications might be when you apply the law of consent and refusal and consider aspects of religious circumcision, blood transfusion in Jehovah's Witness, request for cosmetic surgery to be undertaken for commercial reasons from a parent on their children, the prescription of contraceptive pills in a girl under the age of 16, and as to what the law is in relation to termination of pregnancy and as to what rights the biological father may have. Consent represents legal and ethical right of autonomy and self-determination. This means that this is an inherent right. Nobody has to grant it. It is automatically granted. And if a patient has competence, then it must be respected under law. We will also discuss the impact of English law of consent and how it differs with the informed consent, which is now the rule under the GMC. With a lack of consent, any attempted treatment by a healthcare professional would be regarded as assault and battery and would therefore be a crime under investigation by police or under the criminal courts. But treatment without consent may also be tried as an act of negligence under a civil court, that the doctor had a duty to take consent and neglected to do so, so the doctor could be sued. To be able to offer consent, an adult requires competence, which means mental competence. And competence means someone who possesses capacity. So a person, an adult with capacity, is solely responsible for his welfare insofar, and his decision needs to be respected if he has capacity. So who has capacity? Capacity is the ability to receive and retain information, believe in it, weigh the information to reach a decision, and transmit this information. So relating it to a common scenario, the doctor says to the patient, you have pain and soreness on the right lower side of your tummy, and my clinical diagnosis is acute appendicitis. If we do not treat it, it can burst and lead to infection all over the body. And we can stop all that by undertaking an operation under general anesthetic. You will not feel any pain during the operation, and you will be cured. and would you like us to proceed with this operation? And the risks are infection, failure of operation, complications, complications of surgery and anesthetic. So would you like us to proceed with it? And the patient says, yes. And the doctor would say, what did you understand from my explanation? And the patient says, oh, you said that I have a hot appendix and that it can burst and poison me everywhere, and that you could cure me taking the appendix out. You've also mentioned some possible risks that I've understood it, but I'd like you to go ahead. So this is a person who has exhibited a capacity. Children may not be able to do that. So the general principles of how the patient can communicate consent would be by speaking and saying, yes, go ahead, or signing a piece of paper with written consent, or by conduct. So the nurse says, can I take your blood pressure? And the patient lifts up the arm, ready for the blood pressure cuff to be applied. And that is consent by conduct. If the patient asks, doctor, what are the risks and chances of me dying? Then the doctor has to truthfully answer the question, saying that 0.05% of patients who undergo anesthetic for tummy surgery can die or suffer from serious consequences. So in what conditions is the consent invalid? So if a porter with a white coat and having something sticking out of his pocket, which looks like a stethoscope, gives a folder to a patient to say, oh, the nurse has asked me to get you to sign this. And he may think that this is a doctor. He wouldn't know it's a porter, and he signs it. So this is taking consent through fraud. Duress is something where someone intimidates a patient, saying you need to sign or you do not need to sign. And the patient is under obligation to this person and obeys their commands. So the consent taken by the doctor will not be valid. Or someone who lacks capacity, such as someone who is confused from high alcohol consumption or under a habit-forming drug. And so the doctor says, oh, you've got an appendix and we need to do the operation. And he says, oh, doctor, I live in Colchester. So obviously you can't take a consent when someone has a lack of capacity. So there is a scope of this authority of consent. So the doctor has now taken consent for an operation on appendix. And he has explained that he will be doing this through a laparoscopy or through an open incision. So the doctor undertakes this operation of appendix removal and finds that adjacent to the appendix is a swollen organ called Meckel's diverticulum. And the doctor decides that this is also inflamed. So it is not as inflamed as the appendix, which is near enough to getting to rupture. So he takes out the Meckel's diverticulum as well. And then, of course, when the patient is awakened and regains his faculties, the doctor explains that, oh, in addition to your appendix operation, I've removed your Meckel's diverticulum because sooner or later it would have caused problems. Oh, doctor, will it have added a bit more risks to me? Yes, it can, "No, I didn't want it done, doctor. I just wanted you to get on with the job of removing appendix and just leaving things alone, because I have read up as well on the internet that many such cases settle down on their own. But appendix, as you say, was getting enough to rupture, so you did right, but well, you shouldn't have removed my medulla verticulum." So there is a scope of authority and you cannot go beyond the authority. And of course, the consent would, once it's made, it would be valid even if the patient has lost consciousness. And this is the case with any anesthetic. So patient gives consent, undergoes anesthesia, so he has no capacity. So he has no capacity to withdraw the consent if he changes his mind. Not so if the operation is being undertaken for a small lump on the arm under local anesthetic. So the doctor takes consent, explains whatever is needed to explain, and he proceeds with his injection of local anesthetic, makes a cut, and is dissecting the sebaceous cyst carefully so it comes out whole. Suddenly the patient pulls away his arm, saying, "Doctor, no, I've changed my mind. Leave me alone. I'm just going home now." And the wound is actively bleeding. So the doctor says, "Oh, let me stop the bleeding first. And then, of course, you can go away." No, doctor, leave me alone. And I just need to walk out here. Sort of just give me my shirt and I will put that on and I'll just go away. So if the doctor lets go, the patient actually is bleeding. The doctor has inflicted an injury, which is going to continue to bleed because the bleeding is coming in from an injured artery, which the doctor was about to seal off. So all that the doctor can do is to say, "Okay, we'll not do any more. You don't want me to even stop the bleeding, but let me put a heavy gauze pad and tie it up with a bandage, so it will probably stop bleeding after a little while. I still urge that you let me at least stop the bleeding." No, doctor, just put this on and put this on top of my shirt and I'm going." So this is how consent can be given and consent can be withdrawn. Now, this consent and refusal in children is very different. Now, who can consent as a child? Someone over the age of 16, they can't get married if they are less than 18 though. Someone who is Gillick competent, and we need to know what Gillick competence means. Can parents give consent on behalf of their children? If the patient says, "No, I don't want an operation," and the parents say, "This child needs to have this operation," and the doctor agrees, what is right and what is wrong? Can the courts overrule the decision of a child? Well, if it is an adult refuses consent, not even the courts can overturn the patient's decision if the patient has competence or has capacity. So we'll discuss it in that, but suffice it to say that if there is an hierarchy, then the child's refusal can be countermanded by parents, foster parents, social services who have taken on the job of parenthood in children who are under care, by the courts. They can issue a declaration or an order for this operation to take place, even though the child is unwilling to give his consent. So back in 1969, the Parliament passed a law that at 16, children can consent independently for treatment. Oh, that means the doctor has offered a treatment and a 16, 17, or just short of 18 years old child says, "I agree, doctor." The doctor does not have to take permission from the parents. And even if the parents are reluctant, the patient is considered as an adult for accepting the treatment which has been offered by the doctor. Then in 1985, the law was revised and Gillick test came in. And the law now is, and this was decided and enacted by the House of Lords, the House of Lords have said that if a child has sufficient maturity to understand the consequences of consenting, including short and long-term risks versus benefits, then the child is Gillick competent and therefore has capacity to make a decision for the subject or for the matter at hand. So this was tested time and time again. And this law had come about because Mrs. Gillick, who had 5 children, all under 16, wanted the GP to inform her if any of her 5 daughters were given oral contraceptive. And the health authority on behalf of the GP refused to involve the parents, saying that they are competent. So the matter was debated in high courts, then Court of Appeal, and then of course eventually turned up before the Judicial Committee of the House of Lords. And this has further been explained by the Master of Rules, Lord Donaldson, as with a Gillick test, what is involved is not merely an ability to understand the nature of the proposed treatment, but a full understanding and appreciation of the consequences, both of the treatment in terms of intended and possible side effects, and equally important, the anticipated consequences of a failure to treat. So you can see that a Gillick competent child needs to be fairly intelligent, and he needs to have and show ability to understand the treatment, understands its side effects and consequences, what would happen if he has the treatment, what would happen if he does not have the treatment. Well, if it were to be an adult who would be presumed to have capacity until proven otherwise, if he has the capacity, he doesn't have to give reasons. He may have no reasons. He may have silly reasons, such as a ghost had told me that I should have that. And I understand if I don't have the operation, I will suffer these consequences. If I have the operation, I may still have a bit of complication, but I'll get better. And I choose not to have the operation. So a Gillick competent child is more clever than an adult in this respect. So Gillick test is more powerful and more difficult to pass than an adult capacity test. Now, it is understandable that a child of 16 is much more clever, or a child of 15 is a child who is much more clever than a child of 5. And the law lords have not described the age at which a given child becomes an adult like person under Gillick competence. Well, every child is an adult at the age of 16 and more, but under that, it is clear that a 5-year-old child will have less maturity and a 15-year-old child will have greater maturity. So it is very likely that when it comes to, say, a particular way of treatment, the 5-year-old child is unlikely to understand the implications, complications, benefits, and faults of the proposed treatment. But a 15-year-old is likely to understand these. This is where Gillick competence, Gillick test varies with maturity. Now, this is all to do with consensual consent, treatment. So the doctor has examined, the doctor has explained, the doctor has proposed an operation or a procedure or a prescription. What if the Gillick competent child refuses? So the scenario of acute appendicitis now is in relation to a 15-year-old child. So the doctor has explained that not doing an appendix operation will mean rupture, perforation, sepsis, and possible serious consequences and even death. And doing an operation will salvage the child effectively, and the child will have minimal difficulties. The child says, no, I don't want needles. I don't like cuts. I don't want you to go ahead and do an operation. He is Gillick competent because when asked, he would say, oh, you've told me all of these and I've understood it. And you've told me what will happen if I have the operation and what will happen if I don't have the operation. But I don't want to have the operation. I'll just let things settle down on their own. All my life, I had been well. It's just an illness which I have had for a short while. It will also get better. So the doctor has proposed a procedure. The patient has refused. Then who can allow the operation to proceed without the child's consent? And coming back again, how does a GP understand what Gillick competence is? If one relates it to Mrs. Gillick's case, then in order for a child who is under the age of 16 is in the process of being prescribed oral contraceptive, the GP, having done the Gillick test, now knows that the child is mature for age. He wants to exclude the parents, and she understands the implications. She understands the consequences, and that she will remain engaged with sexual activity whether or not she is prescribed an oral contraceptive, but will be harmed without treatment. And of course, in her best interest, is best that the GP prescribes the oral contraceptive pill. And so, in respect of refusal, we have just talked about, parents have rights, but there is a reason why they are given parental rights. They are given parental rights to make decisions which is in the best interests of the child. So they don't have endless rights, and the children have right as well. And so children are protected by parents in a natural sort of way, but a parent is a good parent caring for a child if he respects the child, if he protects the child, and if he advises the child on rights and wrongs. And so the law lords have decreed that children who refuse a proposed treatment do not have absolute veto. A parent or a proxy parent, such as a foster parent or a sort of a health or social services who have charge of the parenthood of a child who is taken away from biological parents, which are proxy parents, or courts can overrule the refusal of a child. Even the learned judges have questioned that in terms of logic, there can be no difference between an ability to consent to treatment and an ability to refuse treatment. So they have recognized that if a child is mature enough to make a decision, the child should be considered to be mature enough to refuse treatment. But law says differently. And the law has again described that parental rights are there for a reason. So these are qualified rights, not absolute rights. Parents are only allowed to make their decisions on the welfare principles. Courts, on the other hand, have inherent or automatic rights and rights given by the parliament that they can veto the refusal, and this they can do on the best interests principle. And the same goes on with clarification in a brain damaged baby as well. And of course, judges have explained what the best interests are. So the best interests are not necessarily medical interests, but they encompass emotional and all other welfare issues as well. So looking at the application of law, there can be mismatches that one finds. That in this case called Re-T, there was a Far Eastern baby with biliary atresia brought into a famous children's hospital in London, and the child needed reconstruction, which had involved a liver transplant. And the hospital had offered to do it without costs on humanitarian grounds. Parents refused. And so the health authority then appealed on behalf of the child, saying that parents are wrong. The doctors have proposed the operation. The parents are being silly and they have refused. But in effect, the details are that the parents had 3 other children in the Far East. They had limited funds. They had just about enough money to travel to UK to seek some advice and some treatment and to return, so that they could use their financial assets to caring for all of their children. And this child was important, but the other children were also important. So the president of the Family Division High Court, Dame Elizabeth Butler Schloss, said that for making a decision, the mother and child are one. So if the court decides on one aspect, it will affect the mother as well as the baby. So the court said no. The health authorities' appeal failed. The hospital discharged the child, who had flown over and died in his own country. But the same judge subsequently dealt with a Down syndrome baby with an intestinal obstruction, and this required urgent surgery. The judge decided that in that case of Down syndrome, the baby would recover to be what the baby was before the intestinal obstruction, and therefore allowed the hospital to overrule parental refusal and proceed with the operation. So there is a technical legal mismatch, but the mismatch means different decisions for different conditions. Again, the purpose of the court is to preserve life, and courts are not allowed to give capital punishments. In other words, the courts cannot say, take away the life of this person and we order this, because that has been banned by the parliament many years ago. So there was this case of Siamese twin, and Mary was the weaker twin, having more organs. Jody was the stronger twin. Jody had more organs and Mary had fewer organs. And so if separation was to be undertaken, then the dominant twin, which is Jody, would have survived, but the weaker twin, which is Mary, would die in the absence of organs. The organ couldn't be bifurcated. And then the parents said that under our religious law, We can't have any of the two children killed, so let them go. We don't want separation. And the health authority appealed and won, and the law lords had a dilemma that in ordering separation, one child could survive, the other would surely die. And law lords and judges are not empowered to say, take away life. So there was a dilemma. And so they applied a unique best interest solution. And they said it was in the best interests of the stronger twin Jodi to have the separation, even though that would mean the weaker twin would die. So the judges, one of the judges said that the weaker twin's existence hold nothing for her, that her best interest would be served by an operation which would result in her death. So the order was passed under the best interests principles, and the best interest of the weaker twin was to die. There were many controversies subsequently, and people said that the dominant twin will always have the guilt, that the dominant twin's survival was based on killing of her sister. And obviously this was argued, but eventually everyone yielded. Now, in respect of anorexia nervosa, situation is very different, because the judges have decreed that the condition anorexia nervosa is a mental health condition which distorts the mind. So this child with anorexia nervosa is mentally ill. And if she is mentally ill, she doesn't have capacity. And therefore, the 1983 Mental Health Act could be applied, and under Section 2, she could be admitted against her will to a hospital for mental treatment, or under Section 3, to be admitted and then be treated as well for her mental health condition until she was better. It is controversial whether an anorexic child who is under Section 3 for treatment can be given non-mental health treatment. It can be possible if the disease of anorexia nervosa is a mental health disease, which it is, and that one of the treatments of this particular mental health disease is food. So parenteral nutrition, enteral nutrition, and those kinds of things could be given. So Human Rights Act has changed many things. We have come out of Europe now, and we are not subservient to the Human Rights Act. But the cases which were decided when the Human Rights Act was in force will continue to remain valid. Any law that is now made does not have to remain compliant to Human Rights Act. So the Human Rights Act related to medical practice are Article 2, right to life. That means you cannot be given any treatment which leads into your death knowingly. Article 3, prohibition of torture. That means a patient cannot be subjected to unnatural or unnecessary suffering which degrades them in any way. Article 5, right to liberty and security. That means you cannot be imprisoned, even for good reasons, deprived of your liberty, and be placed in a nursing home with a locked outer door. So there are exclusions in this, but it's a natural right that everyone should have a right to liberty and security, unless there is a special case which is allowed. Article 8, right to respect for private and family life. So that means if a parent says, my child needs to be brought up under this particular religion and custom and culture, then this has to be respected, because everyone has a right to respect for private and family life. The government cannot invade that. Article 9, right to respect thought, conscience, and religion. Now that means a person of Jewish faith can say, under my tenets of belief and religion, a male child before the age of, say, 5 should have circumcision. And so you must allow, even though there is no therapeutic reason. So once again, we have already mentioned that the right to life was treated in an unusual way in respect of the Siamese twins. So we are now coming to the end. You would be able to decide in your own mind, now that there is no Human Rights Act, and that British jurisdiction and judiciary are independent. So what should be the view of a practicing doctor in respect of male circumcision on religious grounds, being able to give blood transfusion to a Jehovah's Witness, cosmetic surgery, such as the case that I had described in the consent and refusals of an adult anyway, that a mother approached a doctor, a family doctor, to say, please refer my child to the plastic surgeons, and I would like her left ear to be split, because she will now get a part in a commercial TV series where this child will be a child actress, but she needs to have a split earlobe. And the GP said that this is not in the best interest of the child, and therefore declined it. So we have already discussed about contraceptive pills in, say, 15-year-olds. The law has changed even under the Human Rights Act relating to abortions. So if a woman who is pregnant seeks termination of pregnancy, and the doctor feels it is for justified reason and agrees with her, the biological father of the pregnancy cannot oppose that. Or if he does oppose it, it will not be valid. So the patient, that is the mother who is pregnant, will prevail. Lastly, just recapitulating it, a GP explained in detail about a joint injection and gave it to the patient. The receptionist walked in with a consent form that needed to be signed, but the surgery has been done. The injection has been given. So the doctor cannot get the patient to sign. He has obviously taken a verbal consent, so he must document that no written consent, but verbal consent had been taken. And of course, the tenets of the informed consent would have been, the doctor would have explained the risks of injection, the complications possible from coming in from the injection, the benefits and harm, and then the verbal consent would be just as valid. But it is advised by the GMC and many of the indemnity organizations that if an intervention is to take place, you must take an informed consent on a piece of paper. So the other example is that a 15-year-old girl was prescribed oral contraceptive, and the doctor made all the explanations, but the patient asked a specific question, if she could still become pregnant if she took it regularly. The doctor said she could not become pregnant, but she did become pregnant, and it is known that there is a failure rate, though very small, with regularly taken oral contraceptive pill. So in this case, the doctor was wrong. He did not truthfully and wholly answer the question which was asked by a billy competent child. So hopefully you will have found this presentation on children's consent and refusal linked to the adults' consent and refusal useful. Thank you for listening to this long presentation. Thank you. There are some other similar presentations on other subjects as well. And if you are interested, feel free to look at these and then go through whichever you find of interest. Thank you for your time.